briefly on the management. We'll try to see in what we can do in this small time. When you look at some of the amphibians in the history of evolution, they are very fortunate because if they have a myocardial infarction which can be produced in the lab, it regenerates and produces the myocytes again. Unfortunately, the human myocardium is not so fortunate. What actually happens is when an infarct occurs, it leads to two kinds of fibrosis. One is at the site of the infarct, the myocytes are dead and they are replaced by fibrosis, and that is a replacement fibrosis. And around the scar, there is what is called as a reactive fibrosis, which is a very important for pathophysiology of what we are going to talk. Now, it was long back, Miller from Josephson lab, this very elegant experiment, I should not say experiment, elegant study on 18 patients who had arrhythmogenic myocardial infarct. So they had an infarction and a VT, and he studied them by putting an array in the surgical lab, surgical theater. And what he found, or they found, was that there were a lot of abnormal electrical potentials during the ventricular tachycardia when they put that array. And even when the sinus rhythm was restored, still some of the abnormal potentials were seen, and in the normal sinus rhythm, which was taken after they resected the scar, all these abnormal potentials were abolished. Now, this laid the foundation for our understanding that abnormal potentials are very important in the genesis of ventricular tachycardia and sudden death. This was a very seminal paper in circulation. Now, then went on to the same lab, Dr. Josephson, in 97, he established that it is not, one can actually endocardially, by means of a catheter, because what was done previously was a surgical. By means of a catheter, you can go into the left ventricle, map the electrograms, and demonstrate that abnormal electrograms replace the normal QRS complex. So this paper is again very important because this lays the basis for our current understanding of ventricular tachycardia and also the current treatment of the ablative strategies which we employ in VT. Now, the biggest challenge all these years, because what started surgically and we had only echocardiogram for a long time, was the challenge of imaging this scar. We all are aware that scar is responsible for all the pathophysiological outcomes of myocardial infarction, but imaging was a clinically felt need. And then came the cardiac MRI, and which actually correlated so well with the histological scar, which could be radiologically non-invasively demonstrated. Sorry. So the late gadolinium is a very important technique to demonstrate a scar. You can see the two, a patient above without scar and with scar. You can see a normal gadolinium from the plasma. It remains in the plasma in patients without scar. Whereas in patients with scar, it goes and infiltrates in the scar, and that is imaged as a late gadolinium enhancement, which we correlate histologically and pathologically as a scar. Now, the importance of scar with respect to the ventricular tachycardia and sudden death was very demonstrated by a study by Clem, about 150 patients or so. What he demonstrated was very important. You can see 4 different LV ejection fractions and patients with scar and without scar. What he demonstrated was that if you have a LV ejection fraction low and with a scar, these patients had a high incidence of VTs and ICD shocks. But patients with low ejection fraction, but we did not have a scar, there were no VT shocks or ICD, showing that it is a scar that is more important than the LV ejection fraction. As you know that LV ejection fraction, time-bound, we have been using as a modality to stratify patients who are at risk of sudden death. And similarly, patients who had good ejection fraction, like 40 or 45, but still had myocardial infarction and scar, they were also at risk of sudden death. So again, scar is more important. And now, next came the quantification of the scar. There are various papers which go on to 10%, 15% and all that. The Clem's paper, he demonstrated that 5% scar demonstrated by the MRI was predictive of ventricular tachycardia events and sudden death. Because you can see that scar size of more than 5%, we used various modalities, including electrophysiological study. And still they showed that an independent predictor on multivariate analysis of prediction of sudden death. You can see that as the ejection fraction reduces, VT increases. That is a well-known fact. There is no brainer about that. But the moment the scar goes up above 5%, then the incidence of ICD shock, appropriate ICD shocks goes up. Now, it is also important to know, I have alluded to in my first slide that there are two types of scars, the replacement fibrosis and the reactive fibrosis. Now, are these both same, or are there, you can differentiate them, which are more arrhythmogenic? Now, it has been found in electrophysiological studies in 3D mapping many times that is a border zone rather than the dense scar which is responsible for the arrhythmias, because it contains the slow conducting isthmus and channels with late potentials and all these things. The challenge again is, can we non-invasively identify these areas, because we've been identifying this only on the 3D mapping. And so what we know from 3D mapping is, this is a 3D map of the left ventricle. You can see the scar which is shown by the red area, the border zone. The pink area is a healthy. In between them you can see the multicolored, or the blue and the yellow. This is the border zone which we are interested in. And this is the area of the reactive fibrosis pathologically. And you can see late potentials like this, abnormal potentials, continuous activities, split potentials, late potentials. All these are the harbingers of the genesis of ventricular tachycardia and sudden death. It will be great if we can image them non-invasively without going to the lab. So what has been realized in the next generation of MRI is that it is a scar characterization is more important than its presence, and that predicts the event. Because you have seen before that scar itself is predictive, but if you can characterize scar, that will be much more important. So that came in the next generation of MRIs, where they brought in the infarct heterogeneity. So they found out, they could actually depict that you had a border zones, which I showed you, which has channels and abnormal potentials. By adjusting the signal intensity with a EDAS software, a specific software which they use, they could actually demonstrate, see within the scar, there's a yellow color area, and this is more indicative of the arrhythmogenic components. So then came the papers on this after demonstrating the proof of concept. 99 post-infarct cardiomyopathies, they followed up for 5.5 years by Demerel et al. And what they showed that, so you can see this is a border zone which was imaged by the MRI. They showed that it was incremental benefit over LV ejection fraction to predict sustained ventricular tachycardias and ICD therapies. So showing that not just the scar, but if you can characterize scar, it is much better. Now, Marchalinsky group invasively, that is in the 3D mapping, showed that within the scar, there were some corridors of low voltage corridors, which they called it as the isthmus. And here, by adjusting the voltage parameters, you could actually demonstrate these low voltage corridors within the scar, and these had late potentials. And these late potentials again predicted ventricular tachycardia, and the ablation of the late potentials got relief from. Now, again, the challenge was to image these channels, which are seen in the electrophysiological lab, and the border zone. And this was done in a big study, the Gaudi CRT study. I'm not, because of the time, I'm just breezing through the various topics. Now, this is a study which they imaged by using the software which I said. They imaged the channels, and they found that if you have channels, and then they created an algorithm like this. So if you have a scar, then you go and see channels. If you have scar and channels, and if you have scars and a border zone mass. So this algorithm they used, that means further characterizing scar, and you can see sensitivity was 100%, specificity 80%, a positive predictive value of 35%, more importantly, negative predictive value of 100%. That is, if you do not have channels on MRI by scar characterization, it's a great thing. You are free, your risk of VT and sudden death is low. So showing that there is a great deal of future if you can standardize this technology to predict sudden death. Because you see, only 35 patients with MADID criteria, we use MADID criteria to predict sudden death and use ICDs. Only 35% of patients with MADID criteria receive appropriate shocks, which is well known. And the disadvantages of using this, all the clinicians are well aware. I need not enumerate them. Inappropriate shocks, and most importantly, ICDs are expensive, not practical to give primary prevention in countries like ours. It's never been, in the last 20 years, we've never been able to do. And most of us are not convinced either. But so with this advent of this kind of technology, we'll be able to stratify them further. Now coming to the last segment which I've been asked to touch upon is briefly about the ablation. Now that we have characterized the scar, presence of scar, characterize the scar. Now what has been found is invasively, if you can map these scars carefully and map these channels and border zones and all the abnormal electrograms which I showed like this. Now data has clearly shown that modification of substrate by ablating these late potentials, the continuous electrical active potentials, has caused freedom from VT and freedom from ICD, appropriate ICD shocks. Most of the centers, patients who have ICDs, who have appropriate ICD shocks, they go in for these kind of procedures and they go in with the objective of reducing the further ICD shocks and prolonging the ICD's life. Now, this is a epicardial, sometimes all of them are not amenable endocardial. This is one of the epicardial map we did in our lab. You can see this potential. After the QRS complex, this is a late potential. You see the size of it. It's one of the giant late potentials. All this patient had, you can carefully see the entire scar, there is a small channel. In the channel, a large giant late potential. And the ablation of this got freedom from recurrent and incessant VT, which this person was having. Now, the other way to systematically do this is by doing the entrainment mapping. There's another methods where you have a hemodynamically stable VTs. The previous ablation strategies are used for hemodynamically unstable VTs or unmappable VTs. Now, whereas if you can have a mappable VT, you can do entrainment mapping. This is a very elegant way of doing VT ablation, where you can actually outline where the loops, outer loop and inner loop, are where the isthmus is. You can actually, by doing various entrainment maneuvers, find out where exactly the isthmus is, ablate there, and as I said, a very elegant way of getting rid of VTs. Now, coming to the last phase of this, sometimes VTs may not be easy to ablate. There are so many situations where you cannot ablate hemodynamically unstable, difficult areas of VTs, VT storms. So it has been last 15, 20 years or so, it has been realized that modulation of the cardiac sympathetic system, because by various levels, can actually get rid of the storms, or actually you can do something to contain the storms. I not say get rid of, contain the storms. There have been various neuromodulation options: surgical sympathectomy, stellate ganglion with local anesthetic injection. There's been a big study on this where they can do a stellate block and in VT storms, but you have to do it multiple times. The number of procedures are multiple. Thoracic epidural anesthesia, renal denervation also has been attempted. And we have also attempted in the recent past radiofrequency ablation of stellate ganglia. We have very few patients where we use the anesthetics who are specialized in pain management. They frequently use blocking of stellate for their purpose, for reducing pain and other things, not for VT. But then when we saw that they could do this, they could also do it in VT. So we had a small number of patients, initial publication, where you can see that in a follow-up of over 2.5 years or so, many of the patients are free of VT, and even those with have VT, they have been amenable to ATP. And all these patients have been VT storm on ventilators and that kind of stuff. So in conclusion, scar post-myocardial infarction is responsible for arrhythmias, structural remodeling, and heart failure. All three are the pathological basis of all the bad outcomes of myocardial infarction is the scar.